Hey everybody, so this is going to be your lecture video over module 13. Mostly it's going to be pretty straightforward stuff. If you have any questions, please let me know. I'm going to go ahead and switch over and look at it. So anyways, you're looking at your basic review. Just make sure the different nerves and the actions of the muscles, know more the muscle groups still. You don't need to know every single muscle. You don't need to know all your AOINs. If you know the action and the nerve, you're going to be good. Make sure you understand and know your special tests, though, and the two actions of the knee. And here's kind of a quick review for some of those special tests. Moving on. So one of the most common injuries is an ACL sprain or tear and repair. Pretty straightforward stuff. You guys know where the ACL is. I'm sure you guys understand what a slight tear of it is. The main thing you need to know with this is that there are some specific precautions. So let's go down to here. Closed chain exercises should not be done in the range of 60 to 90 degrees of flexion. So basically, you can't do a full squat, right? So, and in closed chain. So if you're going to flex the knee past 60 degrees of flexion, you need to make sure that it's open chain if you're doing any exercise with them. The reverse side of that is you shouldn't do any open chain resisted exercises from 45 degrees of flexion to 0 degrees of extension. So the last 45 degrees of extension, you shouldn't do that with any type of resistance at all. And so this applies not just for definitely after the surgery, but really even if they've just sprained it, you should protect that. And the reason is because of that screw home mechanism and that convex on concave movement that we've talked about. It causes shearing. It causes that slide of the tibia on the fibula or the fibula, the femur, sorry, it causes the slide of the femur on the tibia or the tibia on the femur. And so you just need to make sure that you're protecting that ACL until it's fully healed. After surgery, you're not supposed to do either of those activities for 6 to 12 weeks after the surgery, but you still want to protect the ligament too if it's just a strain. And so anyways, here's some exercises that you can use for an ACL sprain from Dr. Joe. Here are some just kind of an overview of what it's like to rehab after the surgery. Patellofemoral pain syndrome. This is just when basically it's caused by your patella not tracking properly on your knee, and it can get pulled to one side or the other. Can be caused by a weak VMO, tight IT band, too strong of vastus lateralis and rectus femoris even will kind of pull that up. And so what this little diagram shows is that your patella has all these forces on it, and if one of these forces kind of gets out of alignment or is too strong, it'll pull this patella the wrong way, and you'll start having patellofemoral pain syndrome. If you have any questions about that, make sure you understand and look at Q angle. We've talked about it before, but just really quick again, Q angle is the measurement from the ASIS down through the mid-knee, and then from the tibial plateau up through the middle of the patella. And so the difference in this angle is what is called the Q angle. And when the Q angle is right, the patella slides up and down really well. When the Q angle is wrong, it kind of pulls everything out of alignment. For males, the normal range is 8 to 14 degrees. For females, the normal range of this angle right here is 15 to 17 degrees. It's because they have a wider pelvis, wider pelvic bowl. And so just know that you can get increased Q angle with a wide pelvis femoral anteversion, which is just internal rotation of the femur. If the femur is too internally rotated, if you have tight internal rotators, it can cause it. Coxa vara, right, can cause it. Genu valgum can cause it. External tibial rotation. So if the tibia down here is externally rotated, it can cause that to track improperly and change and make that a bigger Q angle. Pronated subtalar joint can cause it too. So if you have pronated feet all the way down in your feet, it can cause that problem all the way up. And muscle imbalances. Chondromalacia is actually the softening or wearing away of the cartilage underneath the patella, usually. Anyways, it's usually caused by periods where you're just not moving the body enough, and they had to like immobilize the knee. When I was, I don't know, like 12, I cracked my patella and I had to immobilize my leg, and I had knee pain for years after that, and nobody really knew what was going on. Now I know that I almost probably certainly had chondromalacia, and I, just needed some help. So here's some treatments for that. You can strengthen the VMO, stretch the IT band. It really is very similar and caused by a very similar thing as patellofemoral pain syndrome, right? And so here's a video on how to treat that. IT band syndrome, a very similar problem. This is just caused by the IT band getting way too tight. Usually happens, you'll see it in runners and runners who like to run uphill or upstairs. And it's just caused by keeping the knee bent for too long, and and also putting the leg in positions that are abducted at the hip too much, and the TFL gets tight, and which causes the whole IT band to get tight, and it causes the patella to track to the side, and so it will really kind of cause you some pain. You'll notice, especially when you're doing flexion exercises and when the knee gets moved past 30 degrees of flexion, it's going to drag that patella tendon right here over that condyle. And since it's too tight, this part of the knee, especially the lateral part of the knee and the lateral part of the patella here, will really start to have some very sharp pain. And so if you see lateral pain, especially in a runner, there's a really good chance that it's a tight IT band causing IT band syndrome. So you can look here at just how we go about treating that. If you have any questions, let me know. Here's some good IT band stretches and exercises to deal with IT band syndrome. Meniscal tear or repair, pretty much this is just a tear of the meniscus, something we've talked about. McMurray and Apley's test for that. If it's a small tear, you can kind of protect that area for a while and it will repair, especially if it's towards the outside of the meniscus. But if it's more towards the inside, or the tear is like a deeper, harder tear, they're going to have to go in and surgically repair it. And this goes through the different treatments. So make sure you kind of look over that. This is one you'll see as a PTA a lot as well. And so it's really important you kind of look that one over. Actually, all of these you're going to see pretty commonly. So here's some stretches for meniscal tear, and here's just a kind of overall rehab protocol after a meniscus repair and what that is. Osteoarthritis, just like any other osteoarthritis, is when the joint itself and the bone within the joint starts to begin to kind of break down and fall apart. This is what leads to knee replacements for the most part. And then patellar fracture, which I mentioned I had when I was like 12. They just, go in, and if they need to, they put it back together, or if it's just a partial fracture, they immobilize it in a neomobilizer for a while, just like this one. That's what I wore and that's all these years ago, 30, 40 years ago now. Well, not quite 40, but a little over 30. Total knee replacement or total knee arthroplasty can be called either one. super common. This goes over the treatment for it. Mainly, you're just looking to the first few days get the inflammation down, and as soon as possible, get the leg moving again. You're not supposed to do any resisted exercises for 2 weeks afterwards, according to your book, and maybe possibly longer, depending on the type of cement that they use or if they use cement at all. They normally don't make them have any weight bearing precautions. Oops, you can start lifting weights immediately. I mean, not lifting weights, you can start bearing weight immediately and walking on it. But the main thing is just try and get that range of motion, because they'll get stuck. They'll get stuck with not enough extension sometimes, and especially they'll get tight quads and they won't have enough flexion of the knee. And so the main goal is to just get that range of motion back as quickly as you can, and then start strengthening the quads and the hamstrings again to get the knee moving well. So anyways, here's just kind of a good overview of what you would do. Know these in general and how to treat them, because you just need to. First of all, you'll see them in real life. Second of all, there's a good chance you might see something like this on your final practical, right? So here's a good video over that. If you have any questions after you watch these or go over this, please let me know. Moving on. Here are just some overall contraindications. I actually went over the main one with the ACL. Make sure you know this ACL one. It's a big one. Know the stuff with the total knee, that they're not supposed to do any resisted exercises for the first 2 weeks. And this just kind of explains, once again, the open chain versus closed chain, and that convex on concave and screw home mechanism that we've talked about before. And I think this is just some of the different exercises you can do. Pretty straightforward stuff. Just the main thing is you just need to think about isometrics. Obviously are good for early on. This is good for open chain, but like for an ACL, you couldn't do this with any resistance. Long arc quads, good as you go further. And then step ups, these are actually great for an ACL because it's closed chain, and so you're still getting that extension of the knee that you want, but it's in a closed chain format. You can also do this type of closed chain terminal knee extension. TKEs is what those are called, where you just hold a TheraBand and wrap it right behind their knee, and they push back and fully extend the knee. So it's a really good exercise. Mini squats that go down to about 45 degrees can progress down to 60 degrees with a little more, and then eventually, as long as it's not an ACL in that first maybe 6 to 12 weeks, you can start going down to 90 degrees of wall and mini squats. So anyways, these are just some ideas. Obviously, you can look at your Physio U and other things as well. And if you have any questions or want more ideas during our lab Zoom times, we can do that as well. So I think that's everything. Oh, this is just a clinical example. Once again, you don't have to know anything from this section. It just gives you something to look over if you would like to. All right, that's all I'm